The horrifying reality of medieval dentistry. Your molar is throbbing. It's the 14th century, and you're about to discover that nothing hurts more than the cure. Welcome to the nightmarish world of medieval dentistry, where your pain is just beginning, and the remedies will make you beg for the original agony back. Turn off the lights. Put on some distant screaming and clanking iron. You'll want the full ambience for what's coming next. When pain meets ignorance, the demon in your mouth, you wake up with a familiar throbbing in your jaw. That dull ache that started as a whisper has become a scream. Your molar, the one that's been sensitive for months, has finally betrayed you. In your simple medieval mind, there can be only one explanation for this torment. A toothworm, yes, you heard that correctly, from the 5th century all the way. Until the 1700s, the prevailing belief was that tiny worms bored into your teeth, creating holes and causing excruciating pain as they wriggled and feasted on your dental pulp. These weren't metaphorical worms or symbolic parasites. People genuinely believed that actual physical worms were living inside your teeth, gnawing away at the pulp and nerve endings. The degree of your suffering supposedly corresponded with the worm's activity when it moved around vigorously, boring through sensitive nerves. Your pain was unbearable. When it rested, perhaps sated on your dental tissue, you felt momentary relief. This elegant explanation neatly accounted for the pulsing, intermittent nature of toothache, satisfying the medieval need to attribute suffering to tangible, physical causes rather than invisible bacteria or complex decay processes. This wasn't some peasant superstition either. Learned physicians, the medieval equivalent of today's specialists, fully endorsed the toothworm theory. The concept was so deeply embedded in medieval medicine that elaborate treatments were developed specifically to address these non-existent parasites. Medical texts from China to Europe documented the toothworm's appearance in England. It was believed to resemble an eel, while in northern Germany people imagined it as red, blue, and grey, often compared to a maggot. One popular cure involved coating the aching tooth with honey, then waiting with tweezers in hand, hoping to catch the sweet-toothed pest as it emerged to feast on the treat. Imagine sitting for hours, mouth aching, honey dripping, desperately watching for imaginary worms that would never appear. The sweet substance would seep into the cavity, temporarily drawing out fluid through osmosis, and perhaps providing momentary relief, just enough to reinforce the belief that the worm had been tempted out of hiding, even if you failed to catch it. If honey failed, there were more extreme measures. One medieval remedy suggested holding a candle made of sheep suet, mixed with sea holly seed, near the tooth, while cold water was held under the candle. The belief was that the worms, fleeing from the heat, would drop into the water. The only things dropping, however, were likely hot wax onto your already suffering face, and perhaps your hopes for relief, as this remedy inevitably failed. Even more bizarre was the practice of fumigation. Special concoctions of henbane seeds, a highly toxic plant, would be burned, and the patient would inhale the fumes through a funnel directed at the tooth. The resulting lightheadedness and hallucinations from the poisonous smoke might temporarily distract from the toothache, but at considerable risk to your overall health. Henbane contains scopolamine and hyoscyamine, powerful anticholinergic compounds that can cause delirium, confusion, and even death in high doses, making this cure potentially more deadly than the original ailment in some regions. Practitioners claimed they could physically remove the worm. After applying various herbal preparations to the gum, they would skillfully extract the tooth's pulp, a stringy, nerve-filled tissue that conveniently resembled a small worm, and triumphantly present it as the offending parasite. The patient, desperate for an explanation and eager to believe their suffering was over, rarely questioned this sleight of hand. The toothworm myth persisted with remarkable tenacity across cultures and centuries, eventually fading only when microscopes revealed the true nature of dental decay in the 18th century. But for you, living in the 14th century, the worm is as real as the pain pulsing through your jaw, and equally resistant to your attempts to remove it. What you ate, what ate you? Before we delve deeper into the torturous treatments, let's examine why your teeth are failing you in the first place. Contrary to popular belief, medieval people didn't all have blackened, rotting teeth. In fact, archaeological evidence suggests that only about 20% of teeth from medieval remains show signs of decay, compared to up to 90% in some early 20th century populations. The medieval diet, for all its limitations, was actually quite kind to your teeth. Refined sugar was a rare luxury, used sparingly even by the wealthy. Without sugar bathing your teeth in decay-friendly acids, your oral bacteria had far less fuel to destroy your enamel. Your diet was high in calcium from dairy products, vegetables, and cereals, essentially what modern dentists would recommend as a peasant or common townsfolk. Your meals consisted largely of coarse brown bread, pottage, a thick vegetable stew, occasional meat, particularly on feast days, seasonal fruits, nuts, and cheese. This hearty, fibrous diet naturally cleaned your teeth as you chewed, removing food particles that might otherwise feed decay-causing bacteria. The tough, chewy nature of medieval bread, often made from barley or rye rather than refined wheat, required vigorous mastication, stimulating saliva production that helped neutralize acids and remineralize enamel. But your teeth faced a different enemy, where your daily bread, a staple of medieval life, was made with stone-ground flour containing tiny rock particles. Every bite was like taking sandpaper to your teeth. Over years, this abrasion wore down the deep crevices in your molars, paradoxically making them less susceptible to decay but eventually leading to complete tooth loss. By age 40, if you'd survived the numerous other threats to life in medieval Europe, your molars might be worn nearly flat, with exposed pulp cavities and chronic inflammation. The medieval diet varied dramatically by social class, with corresponding impacts on dental health. If you were fortunate enough to be among the nobility, your diet included more refined foods, spiced meats, and sweet confections. White bread, considered superior to the coarse brown bread of commoners, actually provided less natural cleaning. More damaging still was your access to sweeteners, honey for most of the medieval period, and increasingly imported sugar. If you were wealthy, you faced another dental danger. You might actually have access to sugar, imported at great expense from the Mediterranean and later the Caribbean. Sugar was a status symbol that wealthy nobles used to display their affluence. Initially used as a spice or medicine, by the late medieval period, sugar began appearing in elaborate desserts and confections at aristocratic tables. Queen Elizabeth I, though living slightly after the medieval period, famously had blackened teeth from her sugar consumption, a status symbol showing she could afford such luxuries. Ironically, peasants with their coarser, more fibrous diet often maintained healthier teeth than nobles with their refined foods and occasional sweets. The absence of sugar in the common diet was the single greatest protective factor against tooth decay. Archaeological examinations of medieval cemetery populations often show markedly better dental health among lower-class burials than in the ornate tombs of the wealthy. Dietary deficiencies could manifest in your teeth as well. Periods of famine, all too common in medieval Europe, could interrupt the formation of dental enamel in children, creating horizontal lines or pits in the teeth called linear enamel hyperplasia. These developmental defects, visible in many medieval skeletal remains, served as permanent records of childhood malnutrition or illness. For children, dental development was particularly perilous. Without understanding proper nutrition, many infants were weaned onto inappropriate foods, sometimes as early as 3 months of age. The medieval practice of feeding infants papped bread soaked in milk or water through linen cloths could lead to severe early childhood caries, particularly if honey was added to sweeten the mixture. These sugar rags, the medieval equivalent of a baby bottle, could devastate newly erupted teeth. Seasonal variations affected your dental health too. In winter, fresh fruits and vegetables became scarce, and vitamin C deficiency could lead to scurvy, causing the gums to bleed, swell, and eventually recede, loosening otherwise healthy teeth. Spring brought relief in the form of fresh greens, but also the depletion of winter stores, sometimes forcing people to consume spoiled food that might damage teeth through excessive acidity. Even the water you drank could impact your dental fate. Some regions had naturally fluoridated water sources, providing invisible protection against decay. Others suffered from excessive mineral content that caused staining and calculus buildup. Most medieval people drank weak ale rather than water anyway, a practice that, while potentially causing other health problems, might have provided some protection against waterborne pathogens that could indirectly affect oral health through systemic illness. But all these factors, diet, wear, class, and seasonal variations, pale in comparison to the immediate crisis facing you now. That throbbing molar that's making every heartbeat a fresh agony. Home remedies, pain for pain, now back to your throbbing tooth. Before seeking professional help, a prospect will explore in all its horrifying detail. Shortly, you'd likely try some home remedies. Medieval households maintained a working knowledge of herbal medicine out of necessity. Physicians were expensive and often inaccessible, particularly in rural areas. The lady of the house, the village wise woman, or the local monastery's infirmarian would be your first resource for dental pain. Your options were surprisingly numerous, if not particularly effective. Herbal treatments abounded with ingredients readily available to all social classes. Honeysuckle, ivy bark, and holly leaves were commonly chewed or rolled into balls and placed between the cheek and the infected tooth. The mild analgesic properties of these plants might provide temporary relief, though nothing strong enough to address a serious abscess or exposed nerve. A poultice of red rosewater, softened beeswax, and butter applied with a linen cloth was another popular remedy. Imagine the sticky, waxy mess clinging to your gums as you desperately hope for relief. The roses weren't chosen for their pleasant scent alone. Rose oil contains eugenol, the same active ingredient found in modern clove oil, a natural analgesic still used in dentistry today. The butter and beeswax served as carriers, holding the medicinal compounds against the painful area for those with access to more exotic ingredients. Myrrh and frankincense, the same precious resins brought by the biblical magi, were highly valued for dental complaints. Both have documented antibacterial properties and were chewed to treat gum infections and toothache. These expensive imported resins were more commonly found in monastic infirmaries than peasant cottages. Another example of how social class determined your dental fate: willow bark, containing salicylic acid, the natural precursor to aspirin, was chewed for pain relief. The bitter taste was unpleasant, but the analgesic effect might provide genuine, if modest, relief. Similarly, birch bark, containing methyl salicylate, similar to modern wintergreen flavoring, was used as a chewing stick for both cleaning teeth and managing pain. For the more spiritually inclined, prayer offered another avenue of treatment. In the 14th century, many sufferers prayed to Saint Apollonia, who was martyred by having her teeth extracted. Before being burned alive in the 3rd century AD, her gruesome dental death made her the patron saint of toothache, though invoking her probably provided more psychological than physical relief. Churches throughout Europe claimed to possess fragments of Saint Apollonia's teeth as sacred relics, and the desperate might make pilgrimages to these sites, hoping for miraculous intervention. Medieval medical practice made no clear distinction between empirical remedies, magic, and religious intervention. All were employed together without contradiction. For those who preferred a blend of religion and folk magic, there were charms and rituals. One bizarre treatment involved inscribing an iron nail with sacred words, Ogla mais, Sabioth, mais, Athanatos, then inserting it under the affected tooth before driving the nail into an oak tree. The belief was that as long as the nail remained in the tree, the toothache wouldn't return. To complete the ritual, you had to carve your name on the tree while reciting, "By the power of the Father and these consecrated words, as thou enterest into this wood, so let the pain and disease depart from the tooth of the sufferer." This ritual combined elements of sympathetic magic, transferring the pain from person to tree, with Christian invocation, and was perfectly acceptable even to the devoutly religious. Similar charms involved writing special phrases on parchment and carrying them on your person, or reciting specific prayers while performing rituals at particular times of day. Especially dawn or dusk. Garlic, a staple in medieval medicine, also made an appearance in dental remedies. Crushed and mixed with rock salt, it was applied directly to the painful area, likely causing a burning sensation that temporarily distracted from the original pain. Garlic's documented antibacterial properties might have provided some genuine benefit for infections, making this one of the more effective folk remedies available. More questionable was the application of hot animal dung, usually from a cow or pig, to the cheek over the aching tooth. The heat might provide temporary comfort, but the risk of introducing additional infection was substantial. Nevertheless, this practice persisted well into the 18th century in some rural areas, for the truly desperate alcohol provided temporary relief. Brandy or whiskey-soaked cotton balls were placed on the aching tooth, using the numbing effects of alcohol to dull the pain. The stronger the spirit, the better, though the relief was always temporary, and the risk of addiction to this form of self-medication was real, if unrecognized in medieval times. Some remedies were remarkably dangerous. Mercury and arsenic compounds were sometimes used to kill the toothworm, with predictably toxic results. Lead plasters might be applied to the gum, slowly poisoning the sufferer even as they sought relief. The medieval pharmacopoeia made no distinction between cure and poison. The difference was merely in the dosage and application. For children cutting teeth, even stranger remedies were employed. A necklace of wolf teeth was believed to ease teething pain when worn by an infant. Alternatively, a hare's brain might be rubbed on the gums, a practice as unsanitary as it was ineffective. Desperate parents might even have their child wear a dried mole's foot round the neck or drink water in which blacksmith's tongs had been cooled. But none of these remedies have worked for you. The pain is unbearable now. You can't eat, can't sleep, can't think. There's only one option left, and it's the one you've been dreading. A visit to the barber surgeon. The hygiene that wasn't. Before we follow you to your dental doom, let's take a moment to consider what passed for dental hygiene in medieval times. Contrary to popular depictions of medieval peasants with permanently filthy mouths, people did make efforts to clean their teeth without toothbrushes. Medieval Europeans cleaned their teeth by rubbing them with rough linen cloths. Various pastes and powders were applied to these cloths to help with cleaning and freshening breath. Sage, ground with salt crystals, was popular, as was powdered charcoal from rosemary stems. A mixture of pepper, mint, and rock salt was another common cleaning agent. Most consisted of an abrasive component to scrub away food, particles, and staining, combined with aromatic herbs to freshen breath. The abrasiveness of these mixtures, while effective at removing surface stains, could damage enamel over time, particularly when combined with the already significant wear from coarse food. However, without understanding the microscopic nature of plaque and bacteria, medieval people focused on the visible aspects of dental hygiene, removing obvious food particles, addressing bad breath, and maintaining reasonably white teeth. Those living in the countryside had their own solution, chewing the end of a fresh hazel twig until it became brush-like, then using it to scrub their teeth. This primitive toothbrush was surprisingly effective for removing food particles. Birch, twigs, willow, and oak were also used, with different regions favoring particular woods based on local availability and traditional preference. These chew sticks, remarkably similar to the miswak still used in parts of the Middle East and Africa today, contained natural compounds that could help reduce inflammation and kill bacteria. Even mouthwash existed in a rudimentary form. Medieval people used vinegar-based mixtures to freshen their breath. Cloves, still used in modern dental treatments for their analgesic properties, were steeped to make a mouthwash. Wine, infused with herbs, might be swished around the mouth, combining the antiseptic properties of alcohol with the medicinal effects of various plants. The wealthy might use exotic imported ingredients in their dental hygiene routines. Ground cinnamon, nutmeg, and cloves, all expensive spices from distant lands, appeared in dental preparations for the nobility. These aromatic spices effectively masked bad breath and had genuine antibacterial properties, making them functionally superior to the simpler herbs available to commoners. 4. The truly extravagant. Tooth powders might contain crushed pearls or coral, believed to strengthen the teeth through sympathetic magic, the hardness of these materials supposedly transferring to the dental enamel. While useless medicinally, these luxury ingredients did serve as effective abrasives for polishing teeth, giving wealthy smiles a temporarily brighter appearance. In monasteries, where literacy preserved ancient medical knowledge, dental hygiene might be surprisingly sophisticated. The rule of Saint Benedict, governing monastic life, included provisions for regular washing, and this extended to oral hygiene. Some monastic infirmaries produced their own dental preparations based on recipes from classical sources like Galen and Hippocrates, often including exotic imported ingredients obtained through the monastery's trading connections. The medieval Islamic world maintained significantly more advanced dental knowledge than Christian Europe, preserving and expanding upon classical learning while the West experienced its intellectual decline following Rome's fall. In Islamic Spain and the Middle East, dedicated dental practitioners used sophisticated tools for cleaning teeth and specialized in treatments beyond simple extraction. These practices gradually influenced European methods through medical texts, translated from Arabic during the 12th and 13th centuries. Despite these efforts at hygiene, most medieval people suffered from halitosis by modern standards. The absence of effective cleaning tools, limited understanding of oral bacteria, and diets heavy in pungent foods like garlic and onions ensured that bad breath was common enough to be barely noticed. Contemporary accounts suggest that breath freshening was primarily a concern before intimate encounters or important social occasions, rather than a daily hygiene practice. The concept of preventive dental care simply didn't exist. Cleaning was primarily cosmetic and social, aimed at maintaining appearance and addressing bad breath rather than preventing disease. Only when pain struck did dental health become a concern, and by then, options were limited and universally unpleasant. But all the sage rubbing and vinegar swishing in the world can't help you now. Your tooth is beyond home remedies. You need a professional, and in medieval Europe, that meant one terrifying figure, the barber surgeon, the barber's chair, where nightmares begin. The street is crowded as you make your way to the barber surgeon's shop. You recognize it immediately by the red and white striped pole outside, a macabre symbol representing bloodied bandages wrapped around a staff. Originally, barbers performed bloodletting services alongside haircuts, with the pole advertising. Both services dot your stomach tightens as you approach. Inside, the barber surgeon is finishing a haircut, his sharp tools arranged neatly on a table. These same implements will soon be in your mouth. There is no sterilization, no gloves, no anesthetic beyond perhaps a cup of strong alcohol to dull your senses and fortify your courage. The barber's domain. The barber surgeon was a jack of all trades in medieval healthcare. The same hands that trimmed beards also lanced boils, performed bloodletting, amputated limbs, and yes, pulled teeth. Why this curious combination of skills? Because barbers owned sharp instruments, a rarity in medieval times, and had developed the manual dexterity to use them. In the medical hierarchy of medieval Europe, physicians, the most educated medical practitioners, considered themselves above surgery. They focused on diagnoses and prescriptions based on humoral theory, leaving the bloody work of cutting and extracting to barbers. This division became formalized in 1210 when the Guild of Barbers was created in France, eventually splitting practitioners into those who performed complex procedures versus those who handled routine services like haircuts and tooth extractions. As you enter the shop, the smell hits you first, a nauseating blend of blood, sweat, hair, and the sweet putrid scent of infection. The floor is littered with hair clippings, bloodied rags, and perhaps a tooth or two from earlier patients. In one corner, a basin of murky water holds soiled instruments waiting to be rinsed, not sterilized, merely rinsed before their next use. The barber surgeon himself is a paradoxical figure. His hands, which perform such delicate work, are calloused and stained. His apron bears the evidence of countless procedures, splashes of blood, pus, and other bodily fluids that no amount of washing will completely remove. Yet he is often a jovial character, quick with a joke or ribald story to distract nervous patients. This man is part butcher, part artist, part showman, and he is about to inflict extraordinary pain upon you in the name of healing. You're not the only customer waiting. A young boy sits holding his swollen jaw, tears streaming silently down his face. An elderly woman clutches a rosary, her lips moving in constant prayer. A well-dressed merchant, clearly willing to pay extra for preferential treatment, paces. Nervously, dental pain is the great equalizer. It brings all social classes to the same chair of suffering as you sit in the barber's chair. He examines your swollen face, pressing painfully on your cheek to locate the offending tooth. There's no dental x-ray, no careful probing with specialized tools, just rough fingers pushing into your inflamed gums. He nods grimly. The tooth must come out. Tools of torture. The barber surgeon turns to his collection of instruments, and your eyes widen in terror. These are not the precision tools of modern dentistry, but crude, brutal implements designed for one purpose: to wrench the tooth from your jaw by any means necessary. In the 14th century, the most common extraction tool was the pelican, created by Guy de, named for its resemblance to a pelican's beak. This horrific device was hammered out by a blacksmith, not crafted by a medical instrument maker. The pelican worked by hooking over the tooth while the fulcrum rested on the gum. When the handle was pressed, it would pull the tooth outward and upward. The design of the pelican made it extraordinarily painful to use and often caused collateral damage to surrounding teeth and gums. The barber surgeon's skill determined whether you lost only the offending tooth or several adjacent ones as well. This crude device remained in use until the 18th century, when it was replaced by the equally excruciating dental key. If the barber surgeon didn't have a pelican, he might use simple pliers or forceps, tools that were essentially unchanged from Roman times and were spectacularly inefficient at cleanly removing teeth. These early forceps lacked the specialized designs of modern instruments, which are carefully shaped to fit specific teeth. Instead, medieval forceps were one-size-fits-all affairs, as likely to slip and crush the crown of the tooth as to extract it cleanly. For particularly stubborn teeth, the dental key might be employed, a device that looked like a cross between a key and a corkscrew. The claw would be tightened around the tooth, and then the instrument would be rotated to literally wrench the tooth from the socket. Often, this brutal process would break the tooth into pieces or fracture the jawbone. Some dental forceps even had a steel ball on one handle, used to smash particularly resistant teeth into fragments that could then be extracted piece by painful piece. This sledgehammer approach to dentistry ensured that extraction was a traumatic, bloody affair with significant collateral damage. For children or patients with loose teeth, simpler methods might be employed. A strong piece of horsehair or silk thread could be tied around the tooth and yanked out with a sharp tug. Folk practitioners sometimes attached the thread to a door handle and slammed the door to extract children's teeth, a method that persisted in some rural areas well into the 20th century. If the barber surgeon discovered an abscess, he might use a small metal rod called a cautery, heated until red hot in a brazier of coals. This would be applied directly to the infected area, burning away diseased tissue and simultaneously cauterizing blood vessels to reduce bleeding. The sizzle of flesh and the acrid smell of burning tissue would add to your sensory nightmare. For the wealthiest patients, the barber surgeon might have specialized tools imported from the more advanced medical traditions of the Islamic world. Arab surgeons had developed sophisticated dental instruments, including fine-tipped probes for cleaning cavities and specialized forceps for different types of teeth. These refined tools were rare in medieval Europe, however, and even when available, their use required skills that many European practitioners lacked before applying any of these instruments to your suffering mouth. The barber surgeon might prepare the area with various concoctions, a mixture of narcotic herbs, perhaps opium if available, or more commonly, henbane or mandrake, might be applied to numb the gum. These preparations were wildly inconsistent in their efficacy and often came with their own side effects, including hallucinations, confusion, and potentially dangerous respiratory depression. The extraction, a public performance. You're not alone in the barber surgeon's shop. A small crowd has gathered to watch your ordeal. Dental extractions were often public spectacles in medieval times, a form of gruesome entertainment for those not currently suffering. The culture of public medical procedures served multiple purposes. It provided diversion in a world with limited entertainment options. It demonstrated the practitioner's skill to potential future clients, and it normalized the experience for those who might someday need similar treatment. The barber surgeon hands you a cup of strong wine or ale, your only anesthetic. You gulp it desperately, hoping it will dull the pain that's coming. It won't be enough, not nearly enough. The alcohol might take the edge off your fear, but it cannot possibly match the intensity of pain about to be inflicted. For the wealthy, stronger options might be available. A tincture of opium known as laudanum, or a soporific sponge soaked in a mixture of opium, mandrake, and henbane. These narcotics could induce a twilight state between consciousness and oblivion. But they came with significant risks of their own. As the alcohol burns its way down your throat, the barber surgeon positions you in the chair, tilting your head back. An assistant steps forward to hold you still, a necessary precaution, as many patients thrashed and fought during the procedure. In some cases, especially for children or hysterical adults, multiple strong men might be required to restrain the patient. The psychological trauma of being forcibly restrained while in excruciating pain added another dimension of horror to the experience. The barber surgeon might offer you a stick or leather strap to bite down on, not primarily out of concern for your comfort, but to prevent you from biting his fingers during the procedure. Some practitioners used wooden mouth gags to keep the jaw open, devices that looked more appropriate for torture than medicine. The extraction itself is brutally quick but agonizingly painful. The barber surgeon's rough hands force your mouth open, and the cold metal of the pelican slides against your gum. There's pressure, then excruciating pain as he wrenches the instrument. You hear a sickening crack. It might be the tooth breaking, or perhaps your jawbone. Blood fills your mouth as the barber surgeon works, twisting and pulling. The procedure relies entirely on brute force rather than finesse. The periodontal ligaments that anchor the tooth in its socket are not carefully severed, but violently torn. The sensation is akin to having part of your skeleton ripped out, which, in a very real sense, is exactly what's happening. The pain is so intense that your vision might darken at the edges as your body approaches unconsciousness. A mercy many patients desperately hoped for. Some patients fainted from the pain. A mercy others had to be physically restrained by multiple assistants. The lack of proper anesthesia made dental extraction one of the most feared procedures in medieval medicine. The barber surgeon works quickly, understanding that speed is the closest thing to mercy he can offer. An experienced practitioner might complete an extraction in under a minute, an eternity, when every second is filled with blinding agony. Finally, with a triumphant grunt, the barber surgeon extracts what's left of your tooth, or perhaps several teeth, as precision was not a hallmark of medieval dentistry. He might hold it up for the audience to see, perhaps stringing it on a necklace, with other extracted teeth as a macabre advertisement of his services. Some barber surgeons would create entire displays of extracted teeth, categorized by type, condition, or the difficulty of removal. Professional trophies that simultaneously attracted and terrified potential customers. After the extraction, when the real suffering begins, your ordeal isn't over when the tooth is out. Blood pours from the socket, streaming down your chin and onto your clothes. The barber surgeon might pack the wound with cloth, or perhaps cauterize it with a hot iron. If bleeding is severe, another excruciating procedure. The smell of your own burning flesh might be the last sensory input before you finally succumb to unconsciousness. More commonly, the socket would be packed with substances believed to promote healing and prevent infection. These might include honey, which does have genuine antibacterial properties, wine-soaked lint, or herbal compounds. A mixture of wine and myrrh was particularly favored for its antiseptic and astringent properties. In some cases, the barber surgeon might apply a paste made from cobwebs, surprisingly effective at promoting blood clotting due to their naturally occurring vitamin K. Though hardly sterile, there are no antibiotics to prevent infection, no proper wound care protocols. Many patients developed serious infections after tooth extractions. Abscesses were common, as were more severe complications like sepsis. Without understanding germ theory, medieval practitioners had no concept of sterilization, making post-extraction infections nearly inevitable. The instruments used for your extraction had likely been used on dozens or hundreds of previous patients, with no cleaning beyond a cursory wipe or rinse. Cross-contamination was rampant, and particularly virulent infections could sweep through a barber surgeon's client base like wildfire. Hepatitis, tuberculosis, and various bacterial infections could all be transmitted via improperly cleaned instruments. Pain management after the procedure was minimal and largely ineffective. You might be advised to hold salt water in your mouth, apply various herbal poultices to your cheek, or simply endure until the agony subsided. Wealthy patients might receive opium for pain relief, but for most, recovery meant days or weeks of throbbing pain gradually diminishing to a dull ache. Assuming no complications developed, if you're lucky, the wound will heal on its own. If not, infection could spread to your jaw, your sinuses, or even your brain. Facial infections following dental procedures were a common cause of death in medieval times. What started as a simple toothache could easily end in a painful, lingering death from infection. Ludwig's angina, a potentially fatal infection of the floor of the mouth, was a particular risk following lower molar extractions. Without antibiotics, these deep facial infections could progress rapidly, causing swelling severe enough to obstruct the airway and lead to suffocation. Osteomyelitis, infection of the jawbone, was another dreaded complication. This painful, progressive destruction of bone tissue could lead to pathological fractures, disfigurement, and systemic infection. The jawbone would gradually necrose, sometimes resulting in pieces of dead bone working their way out through the gum or skin in a process called sequestration. These protruding bone fragments, often black with necrosis, created a horrifying appearance that medieval people might attribute to demonic influence rather than bacterial infection. Prayer and pain, religion as anesthesia. Throughout your ordeal, religion offers the only consistent comfort available. Medieval Europe was deeply religious, and suffering was understood within a Christian framework that gave it meaning and purpose. Physical pain was seen as a share in Christ's suffering, a purgative experience that could cleanse the soul while the body was being treated. Before submitting to the barber surgeon's tools, you would likely offer prayers to Saint Apollonia, the patron saint of dentistry and toothache sufferers. According to Christian tradition, Apollonia was an elderly deaconess in Alexandria who during anti-Christian persecutions in the 3rd century had all her teeth broken or extracted as torture, when threatened with being burned alive if she did not renounce her faith. She leaped willingly into the flames, choosing martyrdom over apostasy. This gruesome dental connection made her the natural intercessor for those suffering from tooth pain. Churches throughout Europe claimed to possess fragments of Saint Apollonia's teeth as relics. The desperate might touch these relics to their own aching jaws, hoping for miraculous intervention. Some patients reported immediate relief, a testament to the power of faith, or perhaps the placebo effect, rather than any genuine medical benefit. During the extraction itself, you might clutch a rosary or religious medallion, focusing on prayers rather than pain. The barber surgeon, despite his bloody trade, was himself likely a religious man and might offer brief prayers before beginning the procedure, as much to steady his own nerves as to comfort you. Some practitioners had specific prayers they recited during extractions, creating a ritual that gave structure and meaning to an otherwise chaotic and painful experience. Medieval medicine made no clear distinction between physical and spiritual healing. Prayers, charms, and religious rituals were considered legitimate medical interventions, often used alongside physical treatments. Monastic infirmaries, which provided some of the most advanced medical care of the period, integrated religious observance into their treatment protocols. Masses might be said for patients undergoing painful procedures, and the sacrament of extreme unction, last rites, was commonly administered before risky surgeries, a pragmatic acknowledgement of their potential fatality. This religious framework provided psychological comfort that shouldn't be underestimated. The belief that suffering had spiritual meaning could make pain more bearable. Moreover, the communal nature of religious practice meant that the suffering patient was not alone. Their pain was acknowledged and shared by their community through prayer and ritual. In a world without effective physical anesthesia, this psychological and spiritual support was the closest thing to pain management available to most people. Class divides dental care for the rich, while we followed the experience of an average person seeking dental care. It's worth noting that the wealthy had somewhat different options, though not necessarily better outcomes. Social class determined almost every aspect of medieval life, and dental care was no exception. Nobles and wealthy merchants could afford the services of the most skilled barber surgeons, who might have more specialized tools and greater experience with complex procedures. They could pay for privacy, avoiding the public spectacle of extraction that common folk endured. Their treatments might take place in their own homes rather than in the barber shop, with the practitioner bringing his instruments to them, a service never offered to commoners. Pain management options were more extensive for the wealthy. They might receive tinctures of opium, imported at great expense from the East, or complex herbal preparations available only to those who could pay for them. Wine infused with mandrake root, henbane, or other narcotic plants could induce a twilight state between consciousness and unconsciousness, offering some escape from the worst of the pain. Aftercare was also superior for the privileged. A wealthy patient might retain the barber surgeon to monitor their recovery, changing dressings and applying fresh medications. They could afford to rest and recover, unlike peasants who needed to return to physical labor immediately regardless of their pain. The quality of their diet during recovery would be better, supporting faster healing and reducing the risk of complications. For the truly elite, specialized dental practitioners might be available, individuals who focused exclusively on teeth. Rather than practicing general barbering and surgery, These specialists were rare in medieval Europe, but became more common in the Renaissance period. They might offer more sophisticated treatments, including rudimentary fillings made from lead, tin, or gold for those who could afford such luxury. The wealthy also had access to more advanced prosthetic options, while commoners simply lived with gaps in their dentition. The nobility might receive crude dentures or false teeth. These early prosthetics were typically made from ivory, bone, or even human teeth extracted from corpses or sold by the desperately poor. They were secured with gold or silver wire, creating a painful, unstable, and ultimately useless cosmetic appliance. You certainly couldn't eat with these early dentures, but they might improve appearance for social functions. Despite these advantages, the fundamental limitations of medieval dental knowledge meant that even the wealthiest individuals suffered from dental problems. Queen Elizabeth I, though living slightly after the medieval period, was famous for her blackened teeth and severe toothache, but was reportedly so terrified of extraction that she had a bishop publicly undergo the procedure to demonstrate its tolerability. The bishop's stoic performance convinced no one, least of all the Queen, who continued to suffer rather than submit to the barber surgeon's tools. Smell of decay, halitosis, and social death, beyond the acute pain of toothache and the trauma of extraction. Dental problems in medieval times carried significant social consequences. Chief among these was halitosis, chronic bad breath resulting from dental decay, gum disease, or oral infections. In a society where people lived in close proximity and personal space was limited, severe halitosis could lead to social ostracism as devastating as any physical impairment. Medieval people were acutely conscious of oral odor, despite their generally lower hygiene standards by modern measures. Numerous recipes for breath fresheners appear in medieval medical and household texts, suggesting this was a common concern. Mixtures of cloves, cinnamon, and cardamom might be chewed to mask unpleasant odors. Mouthwashes made from wine infused with mint, marjoram, or rosemary were recommended for those who could afford such luxuries. For persistent bad breath, more elaborate remedies were proposed. One 14th century medical text recommends a mixture of cinnamon, cloves, spikenard, and cardamom to be made into small lozenges and held in the mouth, an early ancestor of the breath mint. Another suggests chewing fennel seeds, parsley, or mint leaves before close conversation or intimate encounters. Despite these efforts, severe dental infections produced odors that no amount of spices could mask. Abscesses, in particular, created a distinctive putrid smell as bacteria destroyed tissue and produced gases as a metabolic byproduct. This smell would permeate the breath and could even be detected coming from the pores as these compounds entered the bloodstream and were expelled through sweat. The social consequences of such obvious decay could be severe. Contemporary accounts mention dragon breath or death breath as reasons for avoiding otherwise eligible marriage partners. In a world where marriages were often arranged for political or economic advantage, severe halitosis might require additional dowry compensation, or even render someone unmarriageable. A social and economic catastrophe in medieval society for those in certain professions, particularly those serving the nobility or handling food. Noticeable oral odor could mean loss of livelihood. Court servants, food tasters, wet nurses, and others who worked in close proximity to the wealthy might be dismissed if their breath became offensive. Without social safety nets, such dismissal could lead to destitution. The psychological burden of chronic halitosis shouldn't be underestimated either. Medieval people contrary to popular belief, were concerned with personal cleanliness and social presentation within the limitations of their time. Awareness that one's breath repelled others could lead to social withdrawal, depression and isolation, particularly in urban settings where close contact was unavoidable. But wait, the spectacle of suffering has only just begun. The festering. Aftermath. You've survived the extraction. Barely. The barber surgeon has been paid. The bloody tooth discarded or added to his macabre collection. Now you stagger home, mouth packed with wine-soaked rags, face swollen beyond recognition. Your ordeal has only just begun. In the days that follow, the real danger emerges. Without antibiotics or proper wound care, infection is virtually inevitable. The extraction site throbs with increasing intensity. Your cheek swells further, the skin stretching taut and shiny. Heat radiates from the wound, and a foul taste fills your mouth as pus begins to form. This is the point where medieval dental patients often died, not from the extraction itself, but from what followed. The human mouth contains hundreds of bacterial species, many of which can become pathogenic when introduced into deep tissues through traumatic extraction. These microbes multiply rapidly in the warm, moist environment of the damaged socket, creating an abscess that can spread with frightening speed. The infection might remain localized, forming a painful but relatively harmless pustule that eventually ruptures and drains. But if you're unlucky, and many were, the infection spreads deeper. It can penetrate the bone, causing osteomyelitis, a particularly painful and persistent infection of the jawbone itself. The bone becomes soft and spongy as bacteria destroy its structure, sometimes causing pieces of dead bone to break away and work through the gum tissue in a grotesque process that medieval observers might attribute to demonic influence rather than bacterial action. More terrifying still is the spread of infection into the deep fascial spaces of the neck and face. Ludwig's angina, a rapidly progressing cellulitis of the submandibular space, can develop within days of a lower molar extraction. The swelling can become so severe that it elevates and pushes the tongue backward, obstructing the airway and causing suffocation. Without emergency intervention, impossible in medieval times. Death comes, quickly and horrifically, as the victim struggles for breath. If the infection enters the bloodstream, sepsis follows, a systemic inflammatory response that medieval physicians were powerless to treat. The patient develops fever, confusion, rapid breathing, and eventually organ failure. Death from dental sepsis was not uncommon in medieval Europe, with some medical texts specifically noting the progression from toothache to fatal fever. Even if you survived the immediate infection, chronic complications might follow. Sinus infections were common after upper molar extractions, as the thin bone separating the tooth socket from the maxillary sinus could be damaged during the procedure. These infections might persist for months or years, causing chronic pain, drainage, and fetid breath. Some patients developed fistulas, abnormal connections between the mouth and sinus that allowed food and liquid to pass from one to the other, a disgusting and debilitating condition. Facial nerve damage was another potential complication. The crude extraction techniques could sever or damage the facial nerve, leading to partial or complete paralysis of one side of the face. Without microsurgery to repair nerve damage, these paralyses were permanent, leaving the victim with a twisted visage that often made them objects of superstition and fear in their communities. The smell of death and decay. Perhaps the most immediately noticeable consequence of dental disease in medieval times was the smell. Without effective oral hygiene, dental infections produced odors that no amount of herb chewing or vinegar could mask. The stench of rotting teeth, necrotic gum tissue, and purulent infection pervaded close quarters and social gatherings. The smell of dental decay is distinctive, a unique combination of rotting food particles, bacterial waste products, and decomposing tissue. As the infection progresses, the odor intensifies, becoming increasingly fetid and pervasive. It emanates not just from the mouth, but seems to exude from the entire person as bacterial byproducts enter the bloodstream and are expelled through breath and sweat. Medieval physicians had a keen understanding of the diagnostic value of smell. They categorized different types of oral odors and their implications: the sharp, acidic smell of simple decay, the putrid reek of gum disease, the unmistakable stench of abscess and necrosis. These smells were documented in medical texts and used to guide treatment decisions long before the bacterial causes were understood. For the sufferer, the smell created social death before physical death might occur. Medieval society, contrary to popular belief, was quite concerned with personal hygiene within the constraints of their technology. Those with severe halitosis faced ostracism, lost marriage prospects, and diminished economic opportunities. Court records occasionally mention foul breath as grounds for annulment of marriage, contracts, or dismissal from service in noble households. The psychological burden of knowing one's breath repelled others led to various compensatory behaviors. Some sufferers spoke with hands covering their mouths or maintained greater than customary distance during conversation. Others became increasingly isolated, avoiding social gatherings where their condition might be noticed. For a society that conducted much of its business face to face and relied heavily on social connections for survival, such isolation could be economically devastating. Religious contexts often forced confrontation with dental odors. The practice of confession brought priest and penitent into close proximity, with medieval penitential manuals occasionally advising priests on maintaining composure when faced with foul breath. The Eucharist, received directly on the tongue, required the priest to come near enough to smell each communicant, a trial for both parties. When dental disease was present, broken jaws and facial traumas, beyond infection, medieval dentistry created another category of suffering: iatrogenic injuries caused by the treatment itself. The crude extraction techniques frequently resulted in fractured jaws, broken facial bones, and soft tissue damage that could be more debilitating than the original toothache. The dental key, in particular, was notorious for causing mandibular fractures. The tremendous leverage applied to remove stubborn teeth could crack or completely break the jawbone, especially in older patients with more brittle bone structure or those with pre-existing bone loss from periodontal disease. Without proper reduction and fixation of the fracture techniques, far beyond medieval surgical capabilities, these breaks often healed improperly, resulting in malocclusion, chronic pain, and facial asymmetry. For such fractures, medieval surgeons employed primitive splinting techniques. A common method involved using silver or gold wire to bind together adjacent teeth, creating a makeshift splint that stabilized the fracture while it healed. This technique, while sometimes effective, often resulted in the loss of the teeth as the wire cut into the gum tissue and disrupted the periodontal ligament. More commonly, patients with jaw fractures were simply advised to maintain a liquid diet and allow the bone to heal naturally, an approach that frequently led to malunion, improper healing, and subsequent functional impairment. Unable to properly close their mouth or chew effectively, these patients faced chronic malnutrition and social stigma from their visible deformity. Soft tissue injuries were equally problematic. The barber surgeon's instruments frequently slipped during extractions, lacerating the gums, tongue, cheeks, or lips. Without fine suturing materials or techniques, these wounds were often left to heal by secondary intention, a slow process that created excessive scarring and sometimes contractures that limited mouth opening or speech. More severe cases might receive crude sutures using materials like silk, linen, thread, or even human hair. Without proper sterilization, these foreign materials introduced additional infection risk. Suture techniques were basic at best, focusing on closing the wound rather than aligning tissue planes for optimal healing and minimal scarring. Nerve injuries were perhaps the most debilitating iatrogenic complications. The inferior alveolar nerve, which provides sensation to the lower teeth and lip, runs through a bony canal in the mandible, making it vulnerable during extractions of lower molars. Damage to this nerve resulted in permanent numbness or tingling of the lower lip and chin, a condition that, while not visibly apparent to others, caused significant functional impairment and accidental self-injury as patients would bite their numb lip without realizing it. The facial nerve, responsible for motor control of the facial muscles, could also be damaged during particularly violent extractions or subsequent infections. Paralysis of all or part of the face followed, creating a mask-like appearance on the affected side and functional problems with eating, drinking, and eye closure. In medieval society, such facial paralysis carried significant stigma, often being interpreted as a sign of divine punishment or demonic possession rather than a surgical complication. The art of false teeth, primitive prosthetics. For those who survived extraction and its complications, another challenge remained: living with the gaps in their dentition. Missing teeth created both functional and aesthetic problems, leading to the development of primitive dental prosthetics for those who could afford them. The earliest forms of false teeth in medieval Europe were not individual replacements, but rather bridges made from bone or ivory, typically from cows or walruses. These crude prosthetics were shaped to approximately match human teeth and bound to adjacent natural teeth with gold or silver wire. They were primarily cosmetic, allowing the wearer to maintain appearances in social settings, but were removed for eating as they provided no functional chewing capability. By the late medieval period, more sophisticated dentures began to appear, though these remained luxury items accessible only to the wealthiest individuals. Full sets of dentures emerged around 1500 CE, typically carved from a single piece of bone or ivory to create an upper or lower plate. These early dentures were notoriously uncomfortable, held in place by springs or suction, and were prone to slipping or falling out during speech or facial expressions. The most infamous denture material of the pre-modern era was human teeth. Though more common in the post-medieval period, the practice of using human teeth in dentures began in the late Middle Ages. These teeth were sourced from executed criminals, exhumed corpses, or purchased from the desperately poor who would extract their own healthy teeth for money. These human teeth were preferable to animal alternatives because they looked more natural, but they decayed quickly and carried significant risk of disease transmission. For those who couldn't afford proper prosthetics, visual trickery might suffice. Queen Elizabeth I, though slightly outside our medieval time frame, famously stuffed cloth into the gaps in her teeth when appearing in public, a practice likely employed by image-conscious nobles throughout the medieval period. Others might blacken their remaining teeth with various dyes to make the gaps less noticeable. Since the contrast between white teeth and empty spaces drew more attention to the missing teeth, the functional consequences of tooth loss went largely unaddressed for most medieval people. Difficulty chewing led to dietary restrictions and potential malnutrition. Missing teeth caused adjacent teeth to shift and tilt, creating malocclusion and additional wear. The alveolar bone that once supported the extracted teeth would resorb over time, changing facial appearance and creating a prematurely aged look, characterized by sunken cheeks and decreased facial height. Speech impairment followed the loss of anterior teeth, particularly problematic for those whose livelihood depended on clear communication: merchants, clergy, teachers, and courtiers. Medieval texts occasionally mention whistling speech as a characteristic of those missing front teeth, a description that captures the sibilant distortion created by air passing through dental gaps. Beauty, pain, and cultural perceptions. Throughout medieval Europe, attitudes toward dental appearance varied considerably by region, time period, and social class. Contrary to modern assumptions, many medieval people were quite concerned with dental aesthetics, particularly the upper classes who could afford to dedicate resources to appearance. The medieval ideal of dental beauty focused primarily on whiteness and completeness rather than perfect alignment. White teeth symbolized youth, health, and moral purity, while blackened or missing teeth suggested decay in both body and soul. Popular teeth whitening methods included abrasive powders made from crushed bone, shell, or salt mixed with aromatic herbs. These provided temporary cosmetic improvement at the cost of enamel erosion and increased sensitivity, a beauty trade-off not unlike those made today for the nobility. Maintaining good dental appearance was part of broader expectations regarding physical presentation. Courtly literature occasionally mentions fair teeth as an attribute of beautiful women, alongside clear skin and bright eyes. Men at court were equally concerned with dental appearance, particularly as missing teeth could impede clear speech, a serious liability in political and diplomatic settings where verbal precision mattered. Among common people, attitudes were more pragmatic. Functional concerns outweighed aesthetic ones, with the ability to chew without pain taking precedence over appearance. Nevertheless, folk remedies for tooth whitening appear in household manuals alongside medical treatments, suggesting that even peasants and townspeople maintained some concern for dental aesthetics when their basic needs were met. Regional variations existed as well. In some areas, particularly those with Celtic influence, deliberate dental modification was practiced. Horizontal grooves were sometimes filed into the front teeth, possibly as a cultural identifier or rite of passage. These modifications, visible in some skeletal remains, suggest that dental appearance could carry social significance beyond simple health indicators. Pain itself carried complex cultural meanings in medieval society. Physical suffering was often framed in religious terms as an opportunity for spiritual growth or penance for sin. Dental pain, being particularly intense and localized, featured prominently in religious metaphors. The concept of hell frequently incorporated dental imagery, gnashing of teeth, unquenchable thirst, and eternal burning sensations, familiar to anyone who had experienced severe toothache or abscess. Contemporary accounts suggest that the ability to endure dental pain stoically was considered a virtue, particularly for men. Chronicles occasionally mention nobles or knights who continued their duties despite visible dental suffering. their endurance framed as evidence of character and commitment. For women, the expectation of silent suffering extended to all physical ailments, dental pain included. The relationship between dental health and broader perceptions of beauty created particular challenges for women. Bad teeth could significantly impact marriage prospects, especially among the nobility where physical appearance formed part of the alliance value. Women might go to greater lengths to conceal dental problems, using various herbal preparations to mask bad breath, or keeping their mouths closed when smiling to hide missing or discolored teeth. Rich mouth, poor mouth, the economics of dental suffering. The stark social stratification of medieval society was plainly visible in the mouths of its members. While dental problems affected all classes, the nature, extent, and management of these problems varied dramatically based on economic status. For the poorest segments of society, serfs, day laborers, and urban poor, dental care was almost exclusively extractive and reactive. Prevention was limited to folk practices passed through generations, and professional intervention occurred only when pain became unbearable. Extraction was often performed by the village blacksmith, who had the necessary tools and strength, if not the anatomical knowledge. These crude extractions frequently resulted in broken roots left in the socket, leading to chronic infection and pain. The working poor craftspeople, farmers, and small merchants might access slightly better care through Gelderfeld. Barber surgeons, particularly in urban areas, they could sometimes afford palliative treatments before resorting to extraction, extending the functional life of their dentition. Nevertheless, multiple missing teeth were the norm by middle age in this population, with complete edentulosum, toothlessness, common among the elderly. The emerging middle class, wealthy merchants, guildmasters, and administrative officials occupied an intermediate position in dental care access. They could afford the services of established barber surgeons with specialized experience in dental procedures and might receive follow-up care to address complications. Some could pay for crude prosthetics to replace anterior teeth, maintaining their professional appearance. Their children might receive preventive interventions like removal of loose, deciduous teeth to facilitate proper eruption of permanent dentition. For the nobility and aristocracy, dental care reached its medieval zenith, limited though it remained by the era's medical knowledge. They could summon the most experienced practitioners to their homes, ensuring privacy and relative comfort during procedures. They had access to exotic painkillers, including opium imported at great expense from the East. Their prosthetics were crafted from the finest materials, ivory rather than bone, secured with gold rather than base metals. Perhaps most significantly, the wealthy could afford to preserve rather than extract problematic teeth. Rudimentary fillings, though ineffective, by modern standards, were available to those who could pay for them. These early fillings used lead, tin, or gold beaten into thin sheets and pressed into cavities. While they couldn't halt decay and often trapped bacteria beneath them, accelerating deterioration, they did temporarily restore function and appearance. Diet played a crucial role in these class distinctions. The medieval poor subsisted primarily on coarse bread, vegetables, and occasional dairy products. A diet low in refined carbohydrates that provided some protection against caries. However, their bread contained stone-ground flour with abrasive particles that accelerated tooth wear. The wealthy consumed more refined carbohydrates and, as international trade expanded, had increasing access to sugar, initially as a rare spice and medicine, later as a food additive. This dietary shift created the paradox that the privileged often had worse caries experience despite better access to care. Occupational factors created additional dental class divisions. Those working in certain trades, millers constantly exposed to airborne flour particles, bakers consuming test pieces of sweet goods, wine tasters subjected to acidic exposures, experienced accelerated dental deterioration specific to their professions. Conversely, certain high-status occupations required good dental appearance, creating economic incentives to maintain oral health. Court officials, diplomats, and clergy, whose roles required clear speech, often invested disproportionately. In dental care, the most profound class difference may have been in the social consequences of dental disease. For the poor, missing teeth were unremarkable, an expected part of aging that carried little stigma among peers. For the wealthy, visible dental problems suggested inability to maintain appropriate appearances and could threaten social standing. This disparity created a greater psychological burden among the privileged, who might go to extraordinary lengths to conceal dental imperfections, including limiting facial expressions or speaking behind a handkerchief. The legacy of medieval dentistry, as we conclude our gruesome tour through the reality of medieval dental care. It's worth considering the lasting impact of these practices on modern dentistry. While the barbaric treatments we've explored seem impossibly distant from contemporary care, they laid the groundwork for the evolution of dental science. The barber surgeons, for all their limitations, established dentistry as a distinct field, requiring specialized knowledge and skills. Their professional organizations, guilds and associations, were the forerunners of modern dental societies. Their empirical approach, learning through observation and experience rather than theory alone, established the practical foundation upon which scientific dentistry would later build. Medieval dental practitioners recognized the connection between oral health and overall well-being, even if they misunderstood the mechanisms involved. They observed that dental infections could lead to systemic illness and death, establishing the conceptual framework for modern understanding of the oral systemic health connection. The elaborate botanical pharmacopoeia developed for dental conditions contained genuinely effective compounds that modern science has validated. Clove oil's active ingredient, eugenol, remains a component of dental sedative materials. Myrrh's anti-inflammatory properties are confirmed by contemporary research. Even the seemingly superstitious practice of using willow bark for pain relief contained the natural precursor to aspirin. Most importantly, the medieval experience of dental suffering created a powerful incentive for improvement. The search for more effective, less traumatic dental treatments drove innovation from the Renaissance forward. When dental anesthesia was finally introduced in the 19th century, its rapid adoption reflected centuries of collective memory of dental agony, a cultural trauma that made painless dentistry seem nearly miraculous. Your tooth is gone. So is part of your jaw. But hey, at least now you can't scream quite as loudly. The memory of the pain, however, will remain a phantom ache that haunts you until your likely premature death from infection, malnutrition, or any of the countless other hazards of medieval life. Sleep well, dear viewer, and be grateful for your modern dentist, terrifying as they might seem. Their sterile needles and whining drills are the gentlest caress compared to what you've witnessed tonight. Your dental nightmares will never be the same. Like, subscribe, and comment the worst toothache you've ever had. Bonus points if you cried, begged for mercy, or promised your firstborn to the dental receptionist in exchange for an emergency appointment. And remember, floss daily, or you might find yourself longing for the comparative mercy of the medieval barber surgeon and his blood-stained pelican. Sweet dreams.